COVID-19 crisis here on DW. I'm Gerhard Elfers. Welcome. It all comes down to how well a health system is prepared for a pandemic. In the end, it's the number of intensive care beds and ventilators that counts. Currently, most health systems outside Italy and France are holding the line, but around the world, hospitals are filling up, and triage might become a reality for doctors sooner or later.
This is the worst-case scenario when treating patients. In France, doctors are forced to make life or death decisions. Patients over the age of 80 will not be put on mechanical ventilators. This process is called triage. The term comes from the French verb trier. It means the sorting of and allocation of treatment to patients. Modern medical triage was invented during the Napoleonic Wars. France, Spain and Italy are the worst affected countries in Europe. More than 100,000 people have been infected with the virus in Italy alone. Nearly 12,000 have died. And the longer the crisis continues, the more often doctors are faced with making some very tough decisions.
And to talk about those decisions, I'm now joined by Dr. Tobias Kurt. He's a physician and epidemiologist and also the director of the Institute for Public Health at Berlin's Charité Hospital, and Professor Eva Winkler, a physician teaching medical ethics at Heidelberg University. Let's start with you, Dr. Kurt. We're not yet doing triage in Germany. Are doctors well prepared for taking these decisions?
Well, doctors are well prepared as other doctors in the world and have good training. And the hospitals and physicians organization prepare, let's say, a theoretical framework. I think when the triage is necessary in Germany, it will be very challenging for the doctors and the medical teams here as well.
Dr. Kurt, how does triage work in a hospital? Is it just one doctor who ends up being the only one responsible and carries this burden?
Well, there are certainly operating procedures in place, but you can imagine eventually you have very short time to decide, in which case it will be left by the treating physician and the medical teams on the side who will get a ventilator and who not. So it's going to be a very challenging situation. So therefore, the support of the local structures, the hospital, as well as the legal system is very important to support these medical teams to make these decisions.
We're talking about these procedures. Professor Winkler, how can doctors and hospitals actually prepare for triage?
Well, I think from an ethical point of view, preparing for these decisions is crucial for two reasons. Because we need uniform rules in order to ensure a fair allocation of resources across teams, across units and hospitals. And because doctors in their everyday clinical work are not familiar and not at ease with such decisions, because the traditional clinical ethics is patient-centered and not apt for allocating patients to different levels of contingency care. So from an ethical point of view, we need to agree on two areas, I think. First, the triage protocols that provide for a step-by-step evaluation and criteria for prioritizing patients. In Germany, several medical associations published a recommendation for triage protocol last week with the Academy for Ethics in Medicine in the lead. And second, each hospital then has to define the process, how these rules should be implemented. And we need, therefore, triage teams that include the expertise of intensive care physicians, but also maybe even clinical ethics committees can support in setting up these processes. I think the most important thing is that doctors, not the only, the individual doctor is not in charge for the whole responsibility taken in these decisions.
That's one key issue, of course. But what about normal doctors, say in the community, village doctors who have COVID patients? Do they also, or might they also face these ethical dilemmas?
I think not those that the decision on who gets on the ventilator is obviously not the primary care physician, but they have other triage decisions if there are many patients whom to transfer to the hospitals. If there are many patients in need. So I think the same criteria of seriousness and comorbidities that go into the triage protocols in the hospitals can also be applied in the periphery for the normal primary care physician, or will be at least of importance for him or her.
Dr. Kurz, coming back to you, how well can you predict, actually, whether a person will probably die even if treated? Isn't that also a bit of a lottery there?
But there are certain physiologic parameters and medical history paired with the medical experience of the treating physician that will help to support your decision. But there's no certainty that the to be made decision is the right one. Also, there's a learning curve, as we know from Italy and Spain, that the teams make different decisions depending on the situation, and there will be certainly a learning curve. However, I'm very convinced that the medical teams will do their very best to really do this triage to the best of their knowledge.
Professor Winkler, coming back to you, as an ethicist, what can you tell a frontline doctor who's facing a decision like that? Could you give us an example?
Well, I think first it would be important to acknowledge that these are tough decisions that are kind of at odds with our common doctor's ethics, and somehow address the tragedy of such dilemmas. And then coming back to those rules and protocols that we have now set up, saying that there are different phases of a pandemic, and if you have not enough ventilators for all patients in needs, you have to prioritize those whom you are more certain that you will that they will survive than others. And there we have clearly laid out criteria, so that, as Professor Kurz said, is the current situation of the patient, comorbidities, frailty is in criteria. But for example, age is not in criteria that went into our recommendations in Germany. And I think the third thing that I would recommend is make the doctor aware of available supports in psychological terms, because we know that this is really a moral and otherwise stressing situation, and these structures are built up now in the hospital as well to relieve the staff in triage situations.
Professor Eva Winkler and Dr. Tobias Kurt, thank you very much. And now, as every day, here's our science correspondent, Derek Williams, with a couple of answers to questions that you have sent in. Keep them coming. Today, it's about how men and women can be differently affected by COVID-19. It's the COVID gender gap.
Studies suggest men are more likely to catch COVID-19 than women. Is that true?
It does indeed appear that men are more likely to test positive for the disease than women are. In other words, men make up more than the 50% of confirmed cases you would expect if the virus infected men and women with equal frequency.
Are men more likely to die from COVID-19 as well?
Here the data is more conclusive, and what it's saying is that men are more likely to die after infection with COVID-19 than women are. The numbers are very striking, for example, in Italy, where over 70% of the confirmed patients who succumbed to the disease were men. So the coronavirus really does appear to be more lethal for men than it is for women.
So why are men more vulnerable than women?
Like so much else about this virus, we just don't know enough at this point to really pin down why it's killing more men than it is women. But researchers have hazarded some guesses. On average, worldwide, more than women do, men pursue behaviors that are considered to be health risks, like smoking tobacco or drinking alcohol. As everyone should know, those risks, those unhealthy behaviors, can also lead to what are called comorbidities. Those are conditions like hypertension or cardiovascular disease or chronic lung disease. Many of the victims of COVID-19 were elderly men with comorbidities. Yet other researchers are trying to cast some light on the issue by focusing on the biological and genetic differences between men and women. Could estrogen be playing a protective role, for example? Maybe. There are also some well-documented immune system differences between men and women. And what's most probable is that all of those factors, social, behavioral, biological, that they're all going to play a role in why COVID-19 is hitting men harder than it's hitting women. There's not going to be a simple, straightforward explanation.
This is
an historic day.
Prime Minister told Parliament that
Whenever you